the first in a series of webinars that the Poverty Alliance will be hosting over the coming months. And for those of you who are new to the Poverty Alliance, the Poverty Alliance is the national anti-poverty network in Scotland. So we're a group of network of civil society organisations, from grassroots community groups to national voluntary organisations, trade unions, researchers, academics, you name it, they're part of our network. Our series of webinars are an opportunity for us to explore what we mean by building back better. We know that the coronavirus has had a significant impact on not only on our health, but also on our economy and our wider social systems. What we want to do through this series of webinars is really look at what it means to build back better. So what it means to really change the systems and the processes that have led to us having such significant levels of poverty and inequality in Scotland and in the UK, and how we come out of this crisis better. So how we ensure that those problems that we entered with are not made worse, and in fact that they are reduced. So that's the context for our webinar today. As I said, this is the first in a series of webinars. We're going to be recording today's webinar, so it will be up on our website following this. I would encourage you to use the Q&A function. We're going to be going through our speakers and then have hopefully 15, maybe 20 minutes towards the end to discuss our questions, to summarise some answers to those questions. And as I said, it's a series of webinars that we've got coming up. So if you want to find out more, visit the Poverty Alliance website or event page. We'll be continually updated as we add new events to that. Now, hopefully, as I said, we had a couple of technical difficulties at the start there, but I'm going to turn first to Jerry McCartney. Jerry is the head of the Public Health Observatory at Public Health Scotland, which is the new part of NHS Scotland that deals with matters of public health. Jerry is well known, particularly in Scotland, for looking at issues of the relationship between poverty and in health. So if we maybe turn now to Jerry. Jerry.
Thank you very much, Peter. So I'll try and share my screen. Apologies if there was technical issues at my end that delayed the start, so apologies. So Peter will be able to see himself briefly, and then if I can just go to start. Okay, so Peter, can you just confirm that everybody can see that slide?
Yeah. Okay,
brilliant. So thank you very much for the introduction and for the opportunity to speak, and I hope this will be of some interest to the group. And apologies for my wild hair. I've got one of those COVID lockdown locks, as it's been termed. So yeah, I do normally comb my hair, honestly. So I've been asked to talk about, oh goodness, I think I've got the wrong presentation up. Sorry, can you just bear with me a second? No, I haven't, I've got the right one. Sorry, so I've been asked to talk about the COVID-19 pandemic and how that's impacting on people, particularly people in poverty, but I suppose just to talk through some of the data and some of the consequences that this will have for different groups in society. And I suppose I want to make the point, first of all, that the COVID-19 pandemic is causing 3 concurrent public health crises, and I'll talk through each of those. I'm going to talk through about the scale of harms from each of these and the inequalities that they are generating. And then I'm going to briefly just summarise, I guess, some of the things that Peter alluded to about what the next steps might be in order to balance these harms and to minimise the long-term population health damage, health inequalities, and also social and economic inequalities. So just to start, so on those 3 public health crises, I guess the obvious one, crisis 1, is the direct impact of COVID-19. So this, I guess, was most acutely framed by Professor Neil Ferguson in his report from Imperial College London that went to the now famous SAGE advisory committee in London. So this was the report they published back in, I think, February, where they detailed the potential mortality that would result from COVID-19. At that point, they were working on pretty basic data, so they were working from assumptions from the Chinese outbreak. But what they did was estimated the impact of different approaches to physical distancing on mortality, and also the different impacts on intensive care unit demands. And this was the main rationale for moving into lockdown, was in order to prevent an overwhelming demand on intensive care units, and to try and minimise mortality as a result. And what they found very starkly, and this has been widely reported, was that the crude number of deaths due to COVID would range from somewhere between 20,000 and over 500,000 deaths, depending on how many controls were put in place. And by controls, what I mean here is everything from hand washing through to the full lockdown and the closure of workplaces and schools. And this was, again, the main rationale for the policy change at that point in time. So this is very clearly articulating the direct harms from COVID-19. But what I think had less airtime and less awareness are the two other crises that run alongside this. So the second is the indirect impacts of COVID-19 and the control measures on the access that people have to health and social care services. So I'm putting up a graph here which shows the percentage change in hospital admissions in Scotland over this last 3 or 4 month period. So it's compared, so the zero line at the top is compared to previous years, so the average in 2018 and 2019. And you can see that up to the start of March, it was just very slightly lower than previous years, but it wasn't particularly different. But from March onwards, the number of people getting admitted to hospital for all causes, including COVID, dropped by almost half. And that clearly created a number of worries for us about whether people who really need healthcare services, whether that's because they're having a heart attack or a stroke or cancer services or whatever, weren't accessing those for whatever reason. When you look at some of the data in a little bit more detail, you can see that the drops are there for medical admissions. That's things like cardiology, so heart conditions and cancer, but also surgical conditions. So that's things like appendicitis or gallstones, kidney stones, that kind of thing. But even for paediatric conditions, there was a notable dip in the number of admissions. So that's a real worry for us to understand why that's the case. Now, there are some reasons that might be fairly benign around this. So, for example, there's less traffic on the road and less people driving, so we might expect a decline in road traffic accidents, and that's a good thing. So this doesn't necessarily mean it's all bad news, but clearly we want to be very sure that people who need health and social care services at the moment are able to access them adequately. And so there's a lot of research and work going on at the moment to try and understand these trends better, to ensure that we're able to mitigate any harms that might arise through this route. The third public health crisis is around the social determinants of health, and I think this one will probably be more familiar to this audience. So this largely stems from the unintended consequences of the physical distancing measures, the lockdown. And we looked at this as part of what's called a rapid health impact assessment that was published in the British Medical Journal just a week after the lockdown was announced. And what we argued there is that the lockdown was very likely to have widespread unintended impacts across the social determinants of health. And these are the different pathways that might occur through. And I'm not going to go through this in detail, but just to pick out a few things. So up at the, I don't know if you'll be able to see my mouse here, but up at the top are the obvious things around people losing work, particularly those who are in precarious employment and perhaps didn't have the benefits of some aspects of the furlough scheme, people losing income around that, people who perhaps work in the grey economy or the black economy. Again, the furlough scheme wouldn't cover incomes around that. And we've seen roughly a 500% increase in claims for universal credit. So we know that this is having a massive impact on many, many people. But of course, the impacts are not simply economic. Over on the right there, the loss of education to school children and indeed to further in higher education students. it's clear. Obviously, there's been a lot of work to try and mitigate that and provide some degree of ongoing education, but there is a real worry, and I think rightly so, that that might not be adequate to minimise the impacts on, for example, inequalities in educational attainment and the attainment gap. Over on the where are we? Yeah, so in the middle here, we've got some worries about social isolation, people being left without social contact, loneliness, the risks that people might have about falling into substance use patterns, the risks of people perhaps being stuck with their abusers. So again, these are all well described now, and there's been a lot of discussion in the media around these, but taking all of this together, there's clearly a number of pathways through which unintended consequences on health, but also on social outcomes might have occurred. All unintended, obviously the intention of the policy is very much to manage and reduce the deaths directly due to COVID-19, and that's entirely understandable and justifiable. But yeah, there's a lot of work required and being done to try and minimise the unintended harms through these other routes. So just to summarise that, clearly the social distancing measures to control COVID-19 are likely to have large impacts on health and health inequalities. That includes economic change, social isolation, family relationships, health-related behaviours, disrupted education, and so on. And we reckon that across all contexts, all countries, it would be people on the lowest incomes who would be most vulnerable to the adverse effects of all of that. And substantial mitigation measures would be needed to reduce these. And clearly we've seen very substantial mitigation measures, although we're trying to advise and check whether these are comprehensive enough or whether there's more that can be done to ensure nobody is in debt. So the next thing I'm just going to quickly talk through is, I guess, the scale of these harms. So this graph here at the moment shows the average crude number of deaths in an average year, so taking the last 5 years prior to this year. And you can see that normally there would be a higher number of deaths in the winter, so you can see that around about the 6th of January you would expect about 1,500 crude deaths a year in Scotland. But that goes down as you come into the spring and summer, and that's kind of what we're going to compare against. So I'm going to put on next the graph for this year for COVID-19 deaths, and what you can see there in the yellow is that there's been about half as many crude deaths again as we would expect for this time of year directly due to COVID. So that's people who have got COVID-19 certified on their death certificates, and that's a big number. We know that it tends to be older people, but the average number of years of life that people are losing from COVID is at 10 or 11 years. So it's not people at the very end of life on average who are dying from COVID-19. But there's actually more deaths over and above those that are certified as COVID-19 that are happening in Scotland. So the top of the red line there is the actual number of deaths that have occurred in Scotland this year. And so you can see that although a large proportion of these excess deaths are explained by COVID-19, we have a number of additional deaths over and above that. Now, some of that plausibly could actually have been COVID-19, and it's just not been certified as such. There may have been some nervousness, particularly at the start of the outbreak or the pandemic, to certify people with COVID-19 if there wasn't testing available, although the guidance did allow for doctors to certify as such. But there is a worry, I guess, that some of these deaths may be due to service access issues or due to the unintended consequences of the lockdown, for example, through loss of income or social isolation and the like. And the good news in this is that the red bar has almost entirely disappeared over the last few weeks. And so almost all of the extra deaths that we are now seeing are certified as COVID-19. And so that is a sort of silver lining to this, in the sense that I think we can be more confident that those excess deaths now are simply due to the direct impacts of COVID-19. But we are worried in the medium to longer term that the population health consequences of the lockdown have yet to be seen. In terms of inequalities in this, so this might be familiar to many people who are watching today. So the deprivation fifths of the population, that's the Scottish Index of Multiple Deprivation. And what we do here is we compare the death rates in different population groups to the Scottish average. So the Scottish average here is 100. And so you can see for the most deprived group on this graph for 2018, was 35% higher than the Scottish average, and in the least deprived group, so it's 0.73 of the Scottish average, so it's 27% below the Scottish average. So that's the gradient that we're kind of used to. It's very unjust and unfair, and lots of us have been working very hard for many years to try and reduce this gradient, but that's kind of what we have come to expect in Scotland, this very marked social gradient in health outcomes. But what I want to show you now is how the recent excess deaths have played out. So the first graph here is the COVID-19 direct deaths over March and April. So the data for May is not yet available. And for the more techie people, these data are age standardised, so it's not to do with the age structure of the population. So what this shows is that the gradient or the inequality in COVID-19 deaths is even larger, even greater, even steeper than what we've come to expect in Scotland. So the burden of COVID-19 is very much being felt in our more deprived communities. Now, there's a number of potential reasons for this, and we're not 100% sure on this yet, but some possible explanations could be that people in more deprived circumstances simply have more comorbidities, so more ill health as a background, and therefore are more vulnerable to this. It may be that more people in deprived areas work as key workers, so they are they work in social care, they work in transport, and they're keeping the country going at the moment, and therefore they're more likely to be exposed. Another possible explanation is that the pandemic has hit our urban centres because they're more connected to London and to the rest of the world earlier than our more rural areas that tend on average to be a little bit more affluent. And so that could partly explain it too, that it might be a bit of a time delay factor around that. The last graph I just want to add to this is all deaths. So this includes all the excess deaths that are include the COVID ones, but also the ones that are not certified as COVID over the last couple of months. And again, you see it's more similar to the long-term pattern, but again, slightly more unequal, meaning that the unintended consequences of the lockdown measures may again be impacting most on our more deprived communities. So just to scale this up, we did a paper that's not been peer reviewed yet, so that means it's not been through the full scientific process, so it needs to be interpreted with a little bit of caution, but it is on preprint, so the link's there for people if they want to see it. And what we took was the Ferguson model, the imperial model that I showed you at the start, and we calculated and converted that into life expectancy estimates, and we compared that to some of the long-term trends around social causes of death, such as suicide, drug-related deaths, and all inequalities. And what we found is that in a fully mitigated scenario where there was only 20,000 deaths, I say only with caution, but when there was only 20,000 deaths, that would still result in a drop of life expectancy of a third of a year of life expectancy in a single year. So really quite a big impact. But in the fully unmitigated scenario, so where we had no lockdown measures, no closure of schools, or what have you, we would expect almost 6 years of life expectancy to be lost in a single year as a result of the pandemic. So that's if we had 500,000 crude extra deaths due to COVID. But we then calculated what this would mean in terms of the long-term trends in inequalities. And what we found that over a decade, the impact of inequalities on life expectancy is actually 6 times greater than even that worst-case scenario of a completely unmitigated COVID-19 pandemic. And that, I think, highlights for me and possibly for you that the long-term trends about inequality, we can't lose focus on that, because ultimately that is what's driving the biggest losses in life expectancy in society at the moment. And although COVID is generating a massive mortality challenge, a massive challenge for all of society, how we build back, and as Peter said earlier, how we build back better will be crucially important to the long-term population health impacts. So just to summarise that, I guess COVID-19 is a potentially massive mortality shock. I don't want to underestimate that in any way, but it is nowhere near as big as the inequality, so-called long emergency, and the long-term trends that Scotland has been dealing with for quite some time. So I just want to give you a little bit of background before I finish, just about the part of this long-term challenge. So this is the projected life expectancy for the UK overall, and the Scottish figures are very similar to this, for women on the left and men on the right, based on the trends from 1990 to 2011. So this is what we would have expected mortality trends to do. And before even the COVID pandemic started, these trends had deviated from the long-term averages. And we'd seen this stalled life expectancy for quite some time. And our best understanding of the causes of that are detailed in this diagram here, and it largely relates to the austerity measures that have been brought in over this decade. So the Equality and Human Rights Commission calculated that the poorest tenth of the population across the UK lost, in real terms, after adjusting for inflation, a drop of household income of over 8%. So that kind of scale of challenge for people's household incomes makes it no surprise that people's health would have suffered as a result. And clearly the kind of mechanisms through which that operated were particularly through the social security system, the changes in the conditionality and the value of those benefits, leading to a variety of pathways, including poor housing, nutrition, health behaviours and so on, to stalled life expectancy trends and increased inequalities. So just to kind of bring it back to I guess, the purpose of this seminar series and what to do. So I think in the short run, we absolutely need to ensure that health and social care services are accessible and used, and we need to do everything we can to mitigate these unintended socioeconomic consequences of the lockdown. But in the long run, I think to improve population health and reduce health inequalities, the evidence base is pretty clear about this, that we need to address the inequalities in income, wealth and power that society has, and we need to take the opportunity to build the economy back better, perhaps to make it far more sustainable, equal and health supporting effort to deal with that long emergency that I've illustrated and bring population health back in Scotland to more European levels. There's a lot of additional data and evidence available through those links that I've provided there, but after the session, if people want to email me or tweet me, I'm very happy to get into individual conversations. Thank you. I'll just stop sharing.
Thanks very much, Jerry. A lot of information there, a lot of detail, and thanks for it. I would encourage our participants to ask questions as we go along, and as I say, we will come to those at the end, and any that we don't manage to address, we will look to get answers from our panelists and pull them together later. I'm going to turn now to Linda, who's going to give us a presentation on the, again, picking up from I guess from where Jerry left off, partly about the bigger, wider public health challenges that we face. So over to you, Linda. Thanks very much.
Thanks very much, Peter. And just to check, everybody can see my screen at the moment? Can you see that? Yeah, great. Okay. So what I'm going to try and do is a couple of things, three things actually. I'm going to follow on from where Jerry has left off in terms of what we know about the current situation and the harms from public health measures in particular, but I'm going to try and put that into an international context and also reflect on some of the writing that's happened recently on both what we need to do now in the next few months in Scotland, but also what some of the other solutions would be in terms of how we move forward as a society. And before I start, just to say that the consortium that I lead, Spectrum, which is funded by the UK Prevention Research Partnership, the Poverty Alliance are a partner in Spectrum, and we've enjoyed working with them so far and very much look forward to doing that in the future across the 10 university teams in the group. So within our consortium, we have a colleague, Professor Sharon Friel from the Australian National University in Australia. And she and colleagues recently wrote a very thoughtful piece, which I'd encourage you to have a look at if you have time, talking about the scale and the complexity of the global crisis caused by the pandemic. It's unprecedented, and I'm going to emphasize that. There are multiple reasons why it's unprecedented, but the main one is that when we've historically seen global conflict, it has been geographically contained to some extent, even though it's had huge impacts, both economic, social, and to health. But this pandemic has affected almost every aspect of human life, and there's not a country in the world that hasn't been untouched by this in some shape or form. But as we've already heard from Jerry, we do have an opportunity now to use some of the changes that have happened as a result of the crisis, and to look carefully at how we organize our societies, and to particularly focus on issues to do with sustainability and solidarity. And I would also argue also equity, but it requires the will of our governments and our intergovernmental organizations to take that seriously. And my personal view is that could go one of two ways, but that has to be at the heart of a program of reconstruction and renewal. So what I'm going to cover is the scale of what's happened and how we need to urgently put that in a global context, and just realize that what we're facing in Scotland in some ways might be worse actually than other countries, and other ways better. What's happened as a result of the public health measures, and I'm not exactly, I'm quite critical of some of the things that have happened recently and how we relate that to morbidity and mortality, and then also talk about these other priorities. So I'm just going to show you a few slides from our World in Data. We've got a colleague from the Usher Institute who now works for them. If you haven't accessed their website, they have amazing infographics and real-time data that's inputted here. And this just shows you a map of the globe with the school closures that we are facing as of yesterday. And you can see there are almost 2 billion children and young people globally who are not in school. As Jerry's also already highlighted, is those who have the least access to education already who are most adversely affected. But this will have very serious consequences, and I'll go on to why that is the case, even if those closures are temporary. The other thing that's happened, of course, this is just an example of the cancellation of public events during the pandemic. You can see that has had global impact. There are very few countries who've not made the decision to basically close most things down. And I think we shouldn't underestimate the disruption to life in terms of our social interactions, how we normally interact and behave as humans, how we normally mark the important events in our life and in our communities, how we interact with others, how we remember others, and also how we maintain relationships. So those have been affected on an unprecedented global scale. And every country is in a different situation. Every government with a country that has cases has tried to implement lockdown measures to some extent. In places like Bangladesh, India, for example, it's incredibly difficult to do that. And even in countries where you've had very small number of cases like Ethiopia, for example, the government's taken very assertive and aggressive action, which the population is really struggling to deal with. So even in Africa, where the case numbers remain low in most places, the consequences of government action will probably far outweigh any health harms from the pandemic. This is workplace closures globally, where there's been a much more nuanced approach. And you can see, just looking across the countries, a voluntary approach to workplace closures required for some sectors of the economy, like the UK, where we've seen more premises than in some countries remaining open. And then other countries where they've really tried to shut almost everything down except bits of the economy that affect key workers and key services for life. And then just to reflect on where we sit globally. Now, it's quite difficult, as I've written in the text on this slide, to make international comparisons. And some of you will have heard a very accurate description, in my view, from my colleague, Professor David Spiegelhalter from Cambridge, just talking about how we need to wait. And the Chief Medical Officer in England has said this as well, to actually compare countries. But by any measure, we are doing appallingly badly. And I think that we will not emerge from this well at all. And that's because we were horrifically underprepared for the scale of what was coming to the UK. So you can see here that in terms of the latest data, this is a 7-day average. So we have the highest number of deaths per million people from COVID. The US is speeding up rapidly, which will probably go ahead of other countries. Brazil is facing huge challenges at the moment. As most of you have heard, Sweden has taken quite a different approach, more supporting this concept of herd immunity and not closing down their society. And only the fullness of time will show whether they actually made the right choice. The countries that you see lower down the slide, these are selected countries. They're not only those in Southeast Asia who were hugely well prepared, like Singapore, South Korea, Vietnam, Hong Kong, etc., but also other countries which for a number of reasons have had fewer cases, either because the transmission of the virus entered their economies and their societies later in the pandemic, or alternatively, like, for example, some of the countries, including in Eastern Europe, who shut their borders very early and contained viral spread. So community transmission was very low. But of course, with some of the LMICs you see on this slide, it still has a long time to run. And these figures may look very different in a few weeks' time. So what are some of the challenges arising from what's happened? Now, Jerry's already gone through most of them, but I'm going to go into a little more detail on some of them. So the first thing to emphasize is that most countries have taken quite a stringent approach to this in terms of trying to lock down their societies and shut down key aspects of the economy. And clearly, that has been required for a number of reasons to deal with the effect on health services, where we saw, for example, as we moved beyond Southeast Asia to Europe, the inability of the Italian healthcare system in the north of the country to cope with the number of cases they were facing, and also transmission within hospitals, which had very severe consequences. But in contrast, southern Italy coping much better. So we've had to respond very quickly, and the response to that has been panic in many cases. So as a result, the measures that we've put in place, and what I mean by public health measures are shutting down the economy, closing education, cancelling mass events, not allowing normal aspects of life to continue. Those are public health measures based on the need to social distance and to protect the health service. So in terms of the harms to physical health, as Jerry's already outlined, clearly we have COVID deaths, many of which will have been avoidable if we'd been better prepared, and also we'd had some of the measures in place that other countries have had, but also these excess deaths, which are particularly occurring at home, just to emphasize that. Around 1 in 4 of the excess deaths in Scotland not recorded as COVID related through National Records of Scotland. Around 1 in 4 of the excess deaths are not recorded as COVID related. Now, as Jerry has said, in the fullness of time, more of those might be attributed to COVID, but there are other causes, including, for example, people with cardiovascular disease who may have a heart attack at home, additional deaths from dementia through people being unsupported, and there may be other outcomes as well. The second one, again, is delayed diagnosis and treatment. So we have on average 100,000 people a month who are screened for cancer in Scotland, so that's 200,000 already who've not been screened. Diagnosis was already operating at about, we had 10 to 20% of lack of capacity. And as we emerge from lockdown, trying to catch up with those cases will mean inevitably poor long-term outcomes for those patients because of delayed diagnosis. That is almost certain, and it will take us quite a few years to see the impact of that. The third issue, which we haven't maybe talked about as much as we should have done, is the alcohol harms that could or could not occur as a result of lockdown. So the data from Alcohol Focus Scotland and Alcohol Concern in England suggests that you have 2 different groups. You have people who are already drinking not very much anyway, or certainly within recommended limits, some of whom have decided to stop drinking during lockdown, and others who almost certainly are those who are already drinking too much and who may be suffering health harms as a result, increasing their alcohol consumption. And that's about 1 in 5 at a population level from both those surveys. And SHAP and others have excellent resources on how to approach this at the current time. But again, I think we may see alcohol attributable mortality as a result of the public health measures. And the fourth one, again, as Jerry's touched on, is the longer term health effects of a recession and unemployment. So looking at previous studies, from my colleague Carol Proper and colleagues, we have good data from the last major recession from 2008. And that resulted in around about 900,000 people in the UK suffering from a chronic health condition as a result of the economic impact of the recession. And that's not just unemployment, it's some of the other consequences that happen and when people don't have access to the resources that you need, as you all know. And then in terms of mental health, I think the data we have now is pretty limited, but I think all of us, even in our own individual circumstances, have been able to reflect on what the consequences of the current situation are for mental health. So just looking at some of the recent surveys, we've got about 1 in 5 people in the UK who are worried about mental illness. And those, in terms of anxiety, that's more common than it has been. Increased levels of depression. We're seeing data from some studies on self-harm, and also there may be probably a small but some additional response in terms of suicide that may be preventable. And the groups that we can be most concerned about in terms of mental health outcomes are clearly children through lockdown are experiencing adverse harm, exposure to things that we know are harmful to their development and their outcomes. Gambling, which again there's research going on in that, and irresponsible behaviour, quite frankly, by some of the gambling industry. Increased rates of domestic violence, that's been reported across Europe, and in fact WHO Europe called for European member states to support their populations as a priority issue around domestic violence. Older people in terms of isolation, particularly those that have less access to digital technologies. Obviously, people with existing mental health conditions who are not able to receive the treatment and support they usually do. people with learning difficulties, and of course frontline workers who will have experienced the consequences of the pandemic, and they may result in mental health consequences for them. And then in terms of the education and the economy, I just want to emphasize that it's really very clear that these school closures will have a long-term impact on some children and young people. And in Scotland, we're potentially facing a situation where our children and young people will have had very limited access to education for 5 months. And I understand that, of course, parents are trying very hard to offer education at home. There's online resources, but even in informal discussions with others, that is pretty limited. Schools have really struggled to adapt to that. And of course, the children who will be most disadvantaged are those who don't have access to those resources and would have benefited most in normal circumstances for being in the environment of a school. And we know that longer term implications of even short disruptions to education go on through the years in terms of skill growth. And for the economy, we have estimates, and these vary, about the impact on gross domestic product, depending on how long the consequences of the lockdown continue, and then also projections for additional rates of unemployment. And of course, we're already seeing that in terms of the sectors that have been shut down. So they employ just under a third of people under the age of 25. Low earners are around 7 times more likely than high earners to work in the sectors that are shut down, and women 3 times more likely. And there is almost no doubt that the gender disparity that we see in employment opportunities will have affected women significantly because of the burden, not only of the type of employment they're in, but also the consequences of what they've been dealing with at home during lockdown. And economic recovery is not likely to be equally distributed. So that will be a big challenge going forward. So that's sort of the painting a picture globally and nationally of some of the challenges we currently face. So where are we now, and what do we need to be thinking about for the next few weeks? So I just wanted to touch on some of the immediate issues that we all kind of need to grapple with. And obviously the Scottish Government has produced their roadmap and the phasing of release from lockdown. There's nothing particularly innovative in here. It's pretty much following what other countries have done who've gradually released lockdown. It's quite similar to what the Northern Ireland government has produced. And we can be pretty confident that there will be a few weeks within each stage. And we know the data the Scottish Government is relying on to allow us to release that. But what I would say is that there are several countries in Europe who are well ahead of us. And even though we've seen reports of additional outbreaks in Singapore and the migrant worker community in South Korea, where they've been very successful, things seem to be progressing pretty well in places like Denmark, even in Italy and Spain, certainly in Germany. So we should have some confidence, I think, that through the summer months, hopefully, if we can implement the key public health measures that we need to now, we will be able to move through this phase and be in a better position to then very carefully look at what happens in the winter months, which could pose particular challenges if we don't have good treatments and we don't have a vaccine, which seems unlikely by the end of the year. So we need to continue with the public health measures, and these are for all of us, social distancing, etc. And that's going to be really hard, particularly I'm really concerned about our young people and the implications for them. And then this test, trace, isolate, test and protect that I just wanted to touch on. And I'll come on to a slide on that in a moment. And then this phased release of lockdown. So I know Anne's going to talk about re-establishing health and social care services. I'm confident we'll be able to do that through time, reopening schools and also workplaces, restoring confidence in particular in our public transport system, which of course is totally impractical to tell most people to drive a car or to get on a bike. So we need to have public transport, and then enhance social safety nets, particularly as furlough support is removed, which it will be. So contact tracing, we've been very late to this. This just shows you a global map of countries that are doing it really well. They have already comprehensive contact tracing in place. This is basically the only measure that's going to get us out of this in terms of the global evidence and how you contain cases in the future. We'll probably need to take a more local approach and think about where we have spikes in cases and how we apply that in Scotland and elsewhere. But of course, from tomorrow, we'll be doing this properly in Scotland, and it does look like the resources and the system are now in place. So I guess a question we would ask for our communities in particular, that the poverty lines and their partners work with, is how do we get to grips with this system, and what does it mean for inequalities of the experience of coming through COVID-19. So people being contacted, asking to voluntarily isolate for 14 days if they've been in contact with somebody who's had a positive test, the anonymity of that, the fact that people who are traced as contacts won't necessarily have access to a test, and just how we get to grips with complying with a new system that for 99% of the population they probably never heard of before and certainly hadn't come into contact with. So that will be really interesting. There's going to need to be good public messaging and support for people as we go through that process. And I think that we will have this in place for many, many months to come until we're through, certainly, the winter. So the last slide I just want to spend a couple of minutes on before I hand over to Anne, and that's just talking about what we do in the longer term. And these are, I suppose, 5 main points, again, drawing on the work of Sharon Friel and others, and I know Kat Smith, Jeff Collin, and others in Edinburgh and elsewhere have been writing about these issues as well. So don't have time to go into all the detail now, but clearly there's an opportunity to rethink how we deal with some of the challenges around climate change and the environment, given that we've seen a fundamental shift away from some of the fossil fuel use and other transports that are options that are harmful for the environment. How do we not only support our health service to get up and running, but support prevention in the longer term and also make a case for continued investment in public health? For labour market reform, how do we think about reducing job insecurity, improving labour standards, and also supporting our governments to think about productive jobs, decent productive jobs. And then the emphasis on education and skills formation, which is going to be crucial, particularly for those groups that have been disadvantaged, not just in education for children, but also further and higher education. And then finally, the concept of social protection. And not only readiness in terms of universality in a time of crisis, but moving forward and focusing on some of the key goods and support that we need for our populations in Scotland and elsewhere. And then the final point I'd make is that this could go one of 2 ways in terms of what we call the commercial determinants of health. Either governments say to industry, you know what, it's a free-for-all. We've got to get the economy going up, running again, and you do whatever you want. We're not going to regulate you too strongly. Or alternatively, coming out of a period of unprecedented state action, there's more confidence to impose restrictions on some of the health-harming industries and producers, which can benefit the well-being of all of us. But that remains an open question. Thank you.
Thank you very much, Linda. Just before handing over to Anne, just to mention that the Usher Institute does have its own series of webinars, which would definitely recommend if you want to get into some of these issues in even more depth. I want to hand over to Anne now. I'd introduced Anne at the start of the session, but Anne, if you would like to just give us your reflections and thoughts from the perspective of a GP working in a disadvantaged community, what you've been experiencing and what you've been seeing. Just ask you to unmute.
Oh, okay. Well, thanks very much, and thanks for hosting the webinar, and to Jerry and Linda for those really interesting slides. I think the public health dimension has really gripped everybody's imagination in some respects, because public health, I think, for a long time has taken really a back seat in community health. The links between general practice and public health have really not been as strong as they probably were. You know, I'm a GP in Govan. I've been there for about 26 years, and we worked through the swine flu pandemic in 2009, and I think it's fair to say at that point we were working very closely with public health colleagues. There seemed to be much stronger links, and I think this pandemic has shown where all our weak links are in the chain of events, whether it's been a lack of having a testing trace strategy, lack of PPE in care homes, and also the civic responsibility and solidarity that have sustained system throughout this pandemic in the community, where I obviously work as a doctor, propping up systems, and that really has been using mutual aid to keep people well at home and connected. And that should be, I think, one of the key things that we recognise as we come out of this pandemic. I don't have slides, so I've just got lots of notes, but I'll try and keep it just about 5 minutes so there's time for questions. And I chair the Depend group in Scotland, and we are obviously intensely interested in health inequalities and the inverse care law, which I think people often roll their eyes about because it often seems like abstract concepts. So I'm going to just try and discuss a little bit about what I think we should be focusing on in terms of community health as we come out of the pandemic. There's some good things and very positive things that have happened during this pandemic in the provision of healthcare in the community, and we've managed to reduce demand. I think that was really crippling general practice, and it's a way of then managing the demand as we come out of the pandemic so that we get back to a more realistic function of working in general practice, where we can focus on patients who've got the most unmet needs, whether that's been vulnerable children and families, whether it's people with long-term mental health issues, comorbidities, the types of patients that we would describe in our Depend populations. And I would encourage you to go onto the Depend website and have a look at some of our reports that are there. And we are going to very soon publish a report on our own reflections of working during this pandemic in Depend communities with Depend patients, which are all over Scotland. So just in no particular order, I think there needs to be now better joined up thinking between public health and general practice so that we can see the woods and the trees. I think public health and general practice have not been as connected as they should be. As I said, during the previous pandemic in 2009, I think there was a better connectivity between both systems. So public health have expertise in epidemiology and identifying the wider determinants of health, and general practice have decades of experience and knowledge of their communities, and there's considerable scope for working closer together, sharing data. And I think the community epidemiology of this outbreak is going to be really interesting. As I say, I work in Govan, it's a Depend practice, got a large percentage of patients that we were really worried about in terms of mortality. Our mortality figures are extremely low, and our morbidity figures as well. So there's something going on there, and I suspect this will vary across Depend communities, but the reflections of local GPs, district nursing, health visiting colleagues that are working in these areas should be part of the wider narrative of the bigger data sets, because I think local data informs bigger data sets. And we do know that much of child maltreatment, domestic abuse, vulnerable children, that'll come out retrospectively. We'll have to look back on the data because it's something that you can't do when you're in the middle of all of this. But I think we have to try and proactively support these very vulnerable patient groups within the community as well, once our general practice starts to work towards a more normalised system. At the moment, we're still quite closed. We triage people coming into practice, and that'll have to be for some time until we're absolutely sure transmission rates are really low and we've got a proper testing strategy, because you have to keep patients and staff safe, obviously. We've dropped a lot of bureaucracy around chronic disease management during the outbreak, and I think the question then is, how do we pick that up but focus on the people who need that intensive input from general practice and not a blanket screening of everybody with the conditions. Some patients are actually managing the conditions extremely well. I have to say patients during the pandemic have been very resilient, coping with phone call consultations, video consultations, and the technology will have to be phased into general practice in a way that is manageable. We still have to have face-to-face consultations. Not everything lends itself, we know that, to technology, because particularly with complex multi-morbid and psychosocial issues, these don't need to translate into video consultations particularly well in terms of quality indicators. But nonetheless, the technology is here, it's kind of forced us to use it much more. That should be seen as an asset, but not overtaking the ethos of good general practice and local community care. I think as we come out, local GP leaders and the clusters will be really key to how we into how general practice transitions into this sort of newer model where we can cope with the demand but manage the demand, and that's in hours and out hours as well. Out of hours has had to change very rapidly as well in Glasgow, particularly from an open system to an appointment system, but that is working, and that's something that we have to keep focusing on because that's key to sustaining patient safety and staff safety. We've worked very sensibly, I think, in the community, blurring all sorts of boundaries between the services. We've worked very closely with community pharmacists who have been absolutely key in some of the delivery of service, helping with palliative care in care homes, delivery of medicines to vulnerable patients, etc. And that's really brought into question the issue of having to write paper prescriptions. You know, why can't everything be done electronically? So there's lots of questions about how we join up our electronic systems in general practice with other services that are really part of the primary care team and absolutely key to how we move forward. I've touched on the technology and where we have to be very careful. It isn't the answer to everything. We still have to remember that inequalities, health inequalities, means that many patients are excluded from technology. They can't manage apps, or they've got problems with health literacy for whatever reason. Elderly people can't manage apps often as well. So we don't want to exclude populations or large segments of the population and widen inequalities as well. So that comes on to the persistence of the inverse care law and the aspect of missingness and how we quantify that. So we need to remember that the deep end research so far has highlighted, for example, that patients who miss more than 2 appointments a year are at high risk of premature death, particularly related to mental health. So how would we manage that in the new GP landscape if we're going to use technology a lot more? How do we hand out technology to patients? Do we have a links worker that helps them deal with it? So these are all things that we will have to ask and will have to be taken into account as general practice moves forward. I am still very concerned about the vulnerable children and families in our practice, because we're kind of minimising contact with very vulnerable patient groups that we would normally have quite a lot of discussion with and about with other members of the team, for example, health visitors and monitoring children and families that need a little bit more support. And that's something that we will need to consider as well as we move forward. I have to say the third sector and volunteering groups have been amazing, and they've just shown in deep end communities, probably all across Scotland, rural communities, wherever you are, they've created a local infrastructure, often with very little support, doing very innovative things to outreach work, fill gaps of services to people that are shielding or socially isolated or vulnerable. And I wonder if there's some issue with funding for these groups and how that could be more secure, because they really have contributed to the essential economy. So lastly, I think she's talked about the global elements of the pandemic. It is a global pandemic, and we are all as strong as our weakest links globally. So if health systems are failing in Africa, for example, and the pandemic is out of control there, this translates to us here. There has to be an interconnected approach to the pandemic that we understand even in our own small communities. And we just simply can't go forward just taking our old issues and failures with us. The COVID aftermath and how you address it isn't difficult. I think we all can discuss things like universal basic income. I see there's a question about that. We should nationalise our care homes in Scotland, I believe, and bring them into the Health and Social Care Partnership and imagine them as part of the health service. But it's more difficult to realise that. And we have to ask why that is, why there's still fundamental issues with moving forward into the way that we would think would be better for society. And then the basis of it all is trusted relationships and good communication networks. These are key ingredients to anything that we do. And without that, we won't innovate and succeed in systems. Just revert to what they want to do, and they go back to the status quo, which gets us into this situation in the first place. And health inequalities and inequalities in social care as well. Are we going to just add new issues to old issues? How do we address the inequity across social determinants of health and health itself? So every proposed change should some question, caveat, what does good look like, so that can be answered as a new policy or a new initiative is rolled out. And I think we have to remember climate change in the middle of all this. This is the most dangerous pandemic of all. It's definitely going to be with us for some time. This is not the pandemic, and there will be more that will come, and we have to be prepared for that. So that's the questions that I just wanted to, or the points that I just wanted to make in my discussion. Thank you very much.
Thanks very much, Anne. Now, we're right up against it in terms of time, unfortunately, but if our panelists are able to, we can maybe hang on just for 5 or 10 minutes to even start to answer some of these questions. Really big questions, lots of great questions coming in, so thank you all for those. What we'll do is maybe just pick a few that maybe have come up a couple of times and try and look at those. Right at the start, we were asked for what the panelists' reflections were on the gendered impacts of COVID-19. We know that, at least in terms of employment patterns and so on, that we expect women will be most severely impacted. But in terms of both clinical and non-clinical impact, what do we expect to see the impact there? Maybe start just whoever would like to answer or have a go at that one first.
Shall I start then?
Sure.
Yeah. So, I mean, as we know, men are more adversely affected by the disease when they come into contact with the virus, and the mechanisms for that, I think, are beginning to be better, well understood, and we will see more research on that in future. That seems to be a consistent pattern across countries. But in terms of the people that are writing about the social and economic consequences of the public health measures, there's absolutely no doubt in my mind that the gender dimensions of that are really stark. So I think Scotland actually has a great opportunity to really embed sex and gender perspective in our policy making. And I'd like to see the Scottish Government apply that more consistently. So a sex and gender lens is something the Canadian Government have been very successful at implementing and taken very seriously in recent years. We see that across the provinces. So it's not just Scandinavia that we hold up as an example. So I think in terms of supporting women for employment and just dealing with some of those consequences, that's going to be absolutely key. So the immediate health harms are clearly greater for men, but the social and economic harms will be more significant for women.
And I think, Anne, do you want to come in?
Well, I think that, you know, child well-being, mental health in children is related directly to maternal income, and we know that there's been some great work done by Maura Traynor. I think she's at Stonehenge now at Edinburgh. And I think we have to be very mindful of that, because there are many, many working women who are in precarious positions of employment who will be tipping into destitution. And I hate to use that word, and I think it's appalling you have to, but that will be the reality. So I think some of the campaigns about child poverty are so fundamental to this. Campaigns about housing, universal basic income, I think, is really quite key to many of the discussions we have around the fallout from the COVID pandemic.
Maybe just on that point, to any of our speakers, the question of universal basic income came up a couple of times in relation to, I think all of you, but particularly Linda and Jerry, mentioned the inadequacies of our current social security system. And obviously there's been a lot of discussion around UBI as a potential solution, but just maybe to get some immediate reflections on the possibility of that as part of a solution.
Jerry, do you want to start?
Come in on that? Yeah, so one of the things that I do is I chair the Scottish Citizens Basic Income Feasibility Group. So we've been doing work over the last 2 years funded by the Scottish Government in partnership with 4 local authorities and the Improvement Service to look at the feasibility of this. And that feasibility report will hopefully be released in the coming weeks. I know that there's been some press reports over the last 2 weeks and months that might lead you to think that those pilots are actually ongoing at the moment. That's not the case. We've simply been looking at the feasibility of that. So you expect to hear more on that feasibility report in the coming weeks.
Thanks, Jerry. Anyone else want to?
I just think you know, it has to. These are brave political decisions that people have to make at the highest levels. Because health inequalities, you know, you can talk about how much health can do about health inequalities. For example, 20%, 30% of contribution from health to minimise health inequalities. But unless there are these larger structural policies that determine poverty and build in inequalities into society or address, then, you know, we will never get on top of this as an issue. It'll still be a wicked problem that we're speaking about in 30 or 40, 50 years.
Can I just add one thing to that? Again, looking at the international comparisons, one of the reasons I think we've dealt with this reasonably well in the NHS is because we have a national health service.
Yes.
So if you look at the regional responses in other countries, it's pretty chaotic, actually. Yeah, or under-resourced services. But what we don't have is national other services. You know, we've privatized a lot, we've devolved a lot, etc. I think, Anne, you made the point about care homes, which is very well made, but there are other sectors of our economy as well where I think coming out of a period of unprecedented state action, we really need to think about where else government could be taking action, and also how we deal with some of the consequences of, you know, many years of privatization of some of our essential services. That's a personal view, but I think people are writing about that as well. And just because we probably won't have time, Peter, Kat Smith raised a really important comment in the Q&A in the chat box about, are we doing enough work in Scotland to plan out the long-term future options? And just to flag, the Royal Society of Edinburgh is convening a futures group, but you know, the Royal Society is really not representative of the Scottish population in terms of who's going to be part of those discussions. So I think there's a real opportunity for the Poverty Alliance and others to really actively contribute to that, and you know, future scenario planning beyond the seminars have started.
I mean, I think change also comes from the ground up. So when you look at, you know, what does good look like, where are the really good examples of good working practices that are changing things on the ground, and how do you scale that up? You know, the National Health Service really benefited, I think, because GPs across Scotland closed their doors overnight without a government directive. This was before the lockdown was announced, because we recognised this pandemic was different from the swine flu pandemic that a lot of us had worked through. And we just stopped from being an open access to a closed system. That sends out a very strong message to patients that, you know, there's something very serious going on in the community. So we hope that we helped, I think, reduce some of the COVID-related mortality and morbidity in our communities. But you cannot do that if you know, you do not have a nationalised health service. That would be impossible. We'd be working with different groups of commissioners, etc., and that'd be extremely difficult to do. But I think care homes coming into the health sector and being nationalised is absolutely key as well, because they are an extension of the health service in many respects.
I think some of these issues are undoubtedly ones that we're going to get into in more detail in the weeks ahead in future webinars. And just to say on Kat's question and Linda, your point about the need for us to engage, that's absolutely one of the roles that the Poverty Alliance is taking very seriously at the moment. So we've been engaging with the Scottish Government on their economic recovery group, and we'll be feeding into that as many other in civil society are also doing. But I think there was also a question around lived experience, and I think that's really vital in all of these discussions, that we make sure that people who are being impacted by COVID-19, who have been experiencing poverty for longer times, and those who might be experiencing it newly for the first time as a result of this, that their experiences and voices are heard as well. And again, to reassure the person who raised the question, Poverty Alliance again has already started to do some of that work. We've already brought together a group of community activists to meet with the Cabinet Secretary just last week. So there's still a lot to do in that space. But I think, given that we are running over time, we have got far more questions than we can possibly answer, unfortunately. But we will endeavour to speak to our panellists and to get as many answers to those questions as we can, and we'll post those on our website. We'll also be posting the presentations that we've had today onto the website as well, and you'll receive an email when those are up. Just to finally say thank you to all of our panellists today. This has been our first webinar, so a bit of an experiment for us, but I think it went really well, and really fantastic inputs from all three, so thank you very much for those. Our next webinar will take place on the 11th of June at 11:30, and the topic is returning to work, addressing unemployment after COVID-19. So again, many of the issues that we've discussed today will undoubtedly come up there. Got some great speakers from Resolution Foundation, from Close the Gap, and from the Institute of Employment Studies. So hopefully many of you can join us for that next one. But for now, thank you all very much, and we'll keep in touch. Thank you.
Thank you. That's great. Thanks.